Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Welcome, listeners. This is Tom Urochi, and today's topic is myelofibrosis. Myelofibrosis is a rare MPN or myeloproliferative neoplasm that's associated with progressive bone marrow fibrosis. It has its own subtypes and phenotypes, but almost all patients with myelofibrosis will eventually develop anemia and thrombocytopenia, and some may present with cytopenias. But our guests today are the experts in this area, so let's take a moment for introductions. Dr. Gerds, do you want to introduce yourself?
Hi, thank you. Thanks a lot, Tom, for inviting me. It's a pleasure to be here with Dr. Rampal and Dr. O. My name is Aaron Gerds. I'm Associate Professor of Medicine at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. I specialize in the treatment of myeloid disorders, in particular myeloproliferative neoplasms, and the ensuing clinical trials to improve outcomes for patients.
Awesome, thank you. And Dr. O?
Hello, everyone. My name is Stephen O. I'm an Associate Professor of Medicine and Co-Chief of the Division of Hematology at Washington University School of Medicine in St. Louis. I am primarily focused on patients with myeloproliferative diseases in the clinic, and I also conduct laboratory-based as well as translational and clinical research in the same area.
Great, thank you. And Dr. Rampal?
Tom, thanks so much for the opportunity to be here, and it's great to be here with Aaron and Steve. I'm Rajit Rampal. I'm associate member at Memorial Sloan Kettering and director of the program in MPNs here. Like Steve, I'm a translational scientist, so I take care of patients, conduct clinical trials, and also do bench-to-bedside research on MPNs.
Great. Well, thank you so much, all of you, for making the time to be here today, be a part of this. So let's dive in. The podcast title is Addressing Unmet Needs in Myelofibrosis, and it seems like it's a huge topic. But I thought maybe in this format we could zero in on a few key insights and see where things go. And Dr. Gerds, let's start with you because, would you like to take it from here in terms of anemia and myelofibrosis? I know that we don't have all the answers yet, right?
Clearly anemia is a big problem. It's a prevalent problem. 40% of patients will have anemia at the time of diagnosis, and given enough time, virtually every patient will develop anemia as a part of their disease. And so it's really, really common. It's also prognostic. Anemia has been associated with an inferior outcome for patients with myelofibrosis, no matter which way you slice it. So much so where there's actually a dose response curve. The worse the anemia, the worse the outcome is. So it is a true associated risk factor for poor outcomes in myelofibrosis. And it's very burdensome to patients, right? So someone who's anemic feels anemic, and they feel poorly, they feel run down. It's a burden to get transfusions. We have to have a patient has to come in, get a type and screen, wait for a few hours for the blood to come over to them, and then get the infusion themselves. So, anemia, and specifically transfusion-dependent anemia, can be very burdensome to a patient. So these are the main reasons why we focus on treating anemia in myelofibrosis. It's prevalent, it's prognostic, and it's quite burdensome to patients in healthcare systems.
Yeah, and sort of how are you, without going through all the different scenarios, how are you thinking about treating anemia in a patient with myelofibrosis?
Anemia is multifactorial in any patient with myelofibrosis, and there's some main causes, right? And when we start to think about what are the causes of anemia, we can begin to come up with strategies to attack that anemia. There's anemia of inflammatory block. It goes without saying that myelofibrosis is a disease of inflammation. That inflammation can drive hepcidin levels, for example, and that anemia of inflammatory block can prevent red cell production. There's anemia of dyserythropoiesis, so the mutations inside of the disease leads to dysfunction within the bone marrow, and the bone marrow can't make red cells like it should. There's anemia of treatment, right? Ruxolitinib, the most commonly used JAK inhibitor, leads to anemia in patients, further worsening that feature of the disease. And then in some patients, there's anemia destruction, where the red cells are being either turned over more quickly or destroyed or sequestered in the spleen. There are rare cases of hemolysis as well that can occur in myelofibrosis, but clearly there is an increased turnover of red cells. So all these things kind of combine together in any given individual to result in anemia. So it's not a surprise that a single focus or a singular treatment for anemia doesn't work for everybody, because it is multifactorial and it's often a mix of these things. So we have to hit anemia in lots of different ways when thinking about treatment.
Right, thank you. And with the current landscape, you have different options to choose. I understand that with ruxolitinib, that is a common choice in the first line. But that was interesting also that you called out. One of the cases in your paper was a patient who became anemic on ruxolitinib, I believe, or the dose of rux was adjusted so that because of the anemia. And then, how do you sort of gauge, is that patient getting the full benefit from ruxolitinib in that case, or, what do you do from there?
Yeah. I'm sure Dr. Rampal and O have additional comments on this, but often one of the key strategies to reducing the anemia related to ruxolitinib is just simply reduce the dose. But lower doses of ruxolitinib lead to perhaps less efficacy. We see that patients treated with lower doses have fewer spleen responses, fewer symptom responses. So we really want to maximize both. We want to maximize the ability to preserve red cell production, as well as maximize the ability to control spleen and symptoms, because that we know relates to the best outcomes for patients, whether we're talking quality of life or perhaps even overall survival or other benefits. So really it's walking that knife edge, and sometimes that knife edge is just so narrow you can't walk it. And that's why we need to turn to other agents to address the anemia, so we can maximize the JAK inhibitor as well. And really there are kind of a couple of main strategies. Of course, there are JAK inhibitors who also inhibit ACVR1, lowering those hepcidin levels, leading to improvements in anemia. And then we can also combine JAK inhibitors with anemia supportive agents like ESAs, erythropoiesis stimulating agents, luspatercept and danazol.
Great, thank you. And one of the other things in terms of the overall unmet needs that we talked about individually, Dr. O, was progression on JAK inhibitors. And it seems like sequencing is a hot topic these days. And do you want to sort of unpack progression for us, and what are the different forms of progression, and is there any research in this area that might sort of tee us up for dealing with progression, I guess?
Yeah, absolutely. Thanks, Tom. So, I think, in this disease and this group of diseases, we think of progression as coming in, for lack of a better way to say it, I suppose, different flavors. So there's progression, for instance, on treatment with a JAK inhibitor, such as ruxolitinib. So we know that whether it's ruxolitinib or some of the other JAK inhibitors, that patients will often have an initial spleen and symptom response, and they can maintain that response for an extended period of time, and that's really beneficial. However, over time, many, if not most patients will eventually develop worsening of symptoms or worsening of spleen size in the face of that ongoing JAK inhibitor therapy. And this is also in the context of, as Dr. Gertz was describing, that we have to face treatment-related anemia with some of these JAK inhibitors, and we might consider lowering the dose, which of course will lead to a less potent response in terms of symptoms and spleens. So for all those reasons, there is that type of progression on treatment with a JAK inhibitor. So as you were mentioning, sequencing the different JAK inhibitors, that is an option. That is something that we increasingly will consider for a variety of reasons. And so that's one of the things that we can consider to address that form of progression. Additionally, we have the type of progression that is specifically from a chronic myelofibrosis state, potentially to accelerator blast phase or to acute leukemia. And that is, of course, particularly challenging to deal with. It is driven by a number of different factors, often in the setting of acquisition of high-risk mutations or high-risk mutations that may have been present at an earlier point, and then ultimately do lead to that frank progression to acute leukemia. And so in that context, the sequencing through the JAK inhibitors is not likely to be particularly effective, and that in particular is where we are really needing better therapies and really hoping and needing to identify or better understand what actually is causing that progression. So that's a segue into talking a little bit more about what we know currently and what's been identified recently in terms of what drives these forms of progression. So there have been a variety of studies over the past few years that have really highlighted a theme of, in particular, whether it's progression on JAK inhibitor or progression on to accelerator blast phase, that in particular RAS or MAP kinase pathway activation or mutations in these pathways often come in concert with this. So this has been shown in a number of settings. Some of the recent research from my group has reinforced this. So we conducted a study where we asked a very simple question initially in terms of what genes are expressed at a higher level in patients who progress to acute leukemia from following a history of a chronic MPN. And one of the genes that we identified was a phosphatase called DUSP6, DUSP6. And DUSP6 regulates, amongst other things, ERK and other members of the MAP kinase pathway. And so through the course of a variety of mechanistic and functional experiments, we found that this was one mechanism that we proposed to be driving disease progression through that overall kind of broad pathway. And we've since gone on to flesh this out further, and in particular, we've been focused on a downstream kinase called RISC1, RSK1. And this is all part of the similar pathway, and also we think ties into inflammation, which is a big important core concept of these diseases. And we found that RISC1 seems to promote disease, more aggressive disease development and progression in MPNs, including myelofibrosis, and that targeting RISC kinases seems to be therapeutically effective in our preclinical models. And so this is a concept that we're currently working on in terms of advancing to the clinic. We have been working with a small company called Phoenix Molecular Designs, so a compound called PMD26, which is an oral pan-RISC kinase inhibitor. This compound has been in clinical development for breast cancer, and we're looking to move this into the clinic for myeloid neoplasms. So this is just one example of a number of different strategies to really identify these kinds of pathways that drive disease progression, and then think about how we might be able to translate this into the clinic to intervene for patients in those situations.
Excellent. Thank you, Dr. O. And Dr. Rampal, do you want to take it from here in terms of, I guess we talked about disease modification, and all three of you actually noted that we're not quite there yet to be calling it disease modification, semantics, but, and in terms of what Dr. O and Dr. Gridge just outlined, sort of how are you thinking about the rationale for novel combinations, perhaps, or new targets in this whole big picture of unmet needs?
Yeah, I guess what I would echo what you just said, Tom, which is that disease modification is in many ways it's semantics, because it's you have to ask the question, what does that really mean? I would take a step back and say, on a practical level, right? There's the practicality of what we're trying to do clinically, and then there is the biological goal, right? And the biological goal would be, at the end of the day, to eliminate or suppress the myelofibrosis stem cell or stem cells. But on a practical level for the patient, what we're trying to achieve is to allow patients to live the longest life with the least number of sequelae of their disease or symptoms from their disease, right? That is the goal here, right? Now, what can we do? Well, we have JAK inhibitors, and JAK inhibitors are good at some things. JAK inhibitors are really good at improving symptoms. JAK inhibitors are good at shrinking spleens to a degree, and I'll put an asterisk on that and come back to that in a second. But they aren't good at preventing patients from progressive disease, as my colleagues have kind of talked about. That means different things. That can mean worsening anemia as a consequence of the disease. That can mean worsening anemia as a consequence of the JAK inhibitor. That can mean progression to accelerated or blast phase disease. We really don't have any data that JAK inhibitors prevent, particularly the latter, from occurring. And some of that is, we think, genetically mediated, in that certain mutations, like RAS pathway mutations, seem to cause resistance to JAK inhibition, but then there's innate biochemical processes that cause resistance to JAK inhibitors that have been well documented, and are things that that one JAK inhibitor probably can't overcome for another. Getting back to this concept that you talked about earlier about sequencing therapies, I think you certainly can get some bang for your buck by stopping a JAK inhibitor and reintroducing it, as Dr. Gertz has shown previously, and that might be some of the benefit you see when you switch from one JAK inhibitor to the other. But the fundamental mechanisms that lead to resistance to JAK inhibitors are not things that any of the JAK inhibitors are known to be able to overcome. So that is the limitation. Second thing, coming back to this idea about spleen, right? Is spleen the ultimate endpoint? No, I would argue that some things like progression-free survival are probably the things that matter the most to patients, and of course overall survival. Spleen reduction seems to be at least a reasonable surrogate for inducing clinical benefit, but survival benefit as well. There's data for ruxolitinib and for pacritinib, both showing that if you reduce the spleen by a certain percentage of volume, patients live longer. Why is that? That's a complicated question, and there's lots of answers to that complicated question. But at least there is a correlation there. If you really look at the data, right, and the regulatory endpoint has been a 35% spleen volume reduction, which I don't think anybody believes that 35% is any way a magical number. But if you really look at that as the endpoint, all of the JAK inhibitors, if you look at all of the studies that have used them in upfront trials, only the minority of patients achieve that goal. It's not the majority, right? And so if you are to take it at face value that shrinking the spleen associates with patients doing better, and that you need to achieve some level of spleen volume reduction in order to get benefit, whatever that is, and that is not well defined, then there is real impetus to say, well, we need to perhaps do better. And using combinatorial therapy, that has a good, sound biological rationale, then makes sense because you have an unmet need. Now, is that unmet need shrinking spleens? No, but again, we're using spleen as a surrogate of a broader benefit for patients. There have been, I think in the last decade, there's been an incredible amount of biological discovery that has unveiled different pathways that are important, in these diseases, and that can be targetable at this point. If we think about starting with JAK inhibitors, we still believe in the principle that JAK-STAT pathway activation is the driver of the disease. And so if JAK inhibitors currently work somewhat well, then can you build a better mousetrap? And that is the focus of current ongoing studies. There's new JAK inhibitors, second generation JAK inhibitors, and more selective JAK inhibitors that have entered clinical trials. That I think is an interesting thing, and we'll see what happens. Calreticulin being one of the major drivers of disease, we now think is targetable, and there are several phase 1 trials now trying to directly target calreticulin, which when it's mutated is expressed to some degree on the cell surface. So those studies are undergoing. So there is a concerted effort to better target JAK-STAT signaling. A number of different pathways get activated as a result of the biology of the disease, and we've seen a number of different studies target those pathways. We think about things like BET inhibitors. So pelabresib has finished phase 3 trials, which largely supported there being a clinical benefit and a biological benefit beyond what we've seen with JAK inhibitors, and that came from preclinical studies from a number of years ago. One could probably arguably say the same thing about navitoclax, which clearly did show some clinical benefit, not enough to meet the regulatory approval threshold, but that's sort of a bit of a side note here. It did show that there was actually clear clinical benefit versus patients who just got ruxolitinib alone. So those are two major phase 3 trials that have pointed towards this. There are a number of other drugs that are in development that are early on showing some promise for targets that have been validated, at least preclinically. Things like PIM kinase inhibitors, for example. There's a drug in phase 1-2 trials currently that is shown some clinical efficacy. There is inhibition of MDM2, which regulates p53 expression. The idea that being that if you can inhibit that pathway, you will allow the myelofibrosis cells to perhaps die more than they otherwise would. And there is data that was presented at ASH with navtemadlin this year, and the year prior to that, there was a different MDM2 inhibitor that had shown data in myelofibrosis. So there are a lot of different targets that have shown themselves to be clinically reasonable targets in the sense that there is efficacy that's being shown with targeting these drugs. The question, becomes what are the right patients for combination therapies? When should those be introduced? And then the kind of bigger problem of, how do you get those drugs to be approved, which is beyond all of our pay grades, right? That becomes a relevant question ultimately. So there's a lot going on here, but we have to see some more mature data and see where we go.
Thank you. I just wanted to give you each the opportunity for closing thoughts, and anything that you want to sort of put a finer point on or emphasize in view of the preceding discussion.
I can jump in. I would echo, my colleagues and just emphasize that, we have made tremendous progress in the field collectively. Over the past, say 15 plus years, we have 4 JAK inhibitors that are approved that are used with great benefit overall for our patients. And that said, as described nicely by my colleagues, we have some limitations with trial study design endpoints that make it, in a good way and also a challenging way, a little bit more nuanced in terms of how to move the field to the next level with these other agents, whether it's in combination or as monotherapy. And again, we're hoping to get to that next level with this next era of treatment in this disease group.
We have lots of problems in this field, and we have lots of potential solutions that are, beginning to show hints of promise.
It's been a pleasure. And I think our audience will see that there's a lot going on in this space right now. And with all of this research activity, I think there's hope that we're on the cusp of something, even if we're not quite there yet, in terms of advances in the future. So I think that's a great place to stop. And I'll just say, for more on this topic and many other topics organized by disease state, please visit our website at expertperspectives.com.